We are a comprehensive orthopedic department with all the various facets of orthopedics being available. We have great research. We have 2 PhD doctors in fine laboratories with funded research. We have a great educational organization, and we've intentionally limited fellows because we want our residents to be front and center. Our chief and our 4th-year medical students will always be either the first assist or the surgeons in most of our cases.
The smaller suburban hospital where
and through the process of progressive autonomy over the course of 5 years, they really do become independent, highly skilled orthopedic surgeons.
And what we do is we do volume. This is a high volume orthopedic practice. We also enjoy what we do, and we have a lot of fun while doing it.
This group of personalities and all get along because we all have the same mission and goal.
We really try to encourage them to be engaged outside of work. We not only want them
and just as hard as anyone in the country, but everyone is happy. Everyone has such a good time, and I can tell you that makes it so much better. I love it. I enjoy it. And the reason why is because all the residents, all the attendings, everyone has each other's back, and everyone has such a good vibe, and you don't see that kind of laid back culture in such a hard-working program.
Covers all of pediatric orthopedics in a didactic fashion, and then also provides residents a safe, controlled, stress-free environment to perform 11 of the most common surgical procedures on cadavers or artificial synthetic bones.
So my most memorable moment thus far has been working in the cadaver lab downstairs with the opportunity to place pedicle screws. And the best part about it is that the bone is real. It has the same opportunity to do it before, but this was an excellent experience because I felt like I really started to master the technique.
We work hour restrictions and increasing demand for patient safety. It's become a little bit more difficult to efficiently educate our residents in surgical skills. And it takes much more than seeing one and doing one before you can teach one.
From physically looking at placement of a pedicle screw, you can put your pedicle screw in and then dissect the cadaver out a little bit and actually see physically what it looks like, as it lets you kind of hone your technique a little bit better than just learning as a resident in the operating room.
Another one of the greatest advantages of educating surgeons in a simulated center like this, where it's safe and we're not working on live patients, is the reality that we learn best oftentimes from our mistakes. And mistakes in the spine in a 13-year-old girl, there's no margin for that, and there's no margin for learning. And a true trainer sawbone in the simulation lab or downstairs in the cadaver lab on a cadaver sawbone, residents can make a mistake. There's no complication, there's no anxiety or stress, and there can be an attending spine surgeon right there next to them that can then show them their mistake, and the resident can learn from their mistake without anxiety and without a complication. So that is a tremendous opportunity as a resident, and it's a huge patient safety factor for our patients.
Today I'm going to talk to you about ACL, or anterior cruciate ligament reconstruction surgery. The anterior cruciate ligament, or ACL, is one of the 4 main ligaments connecting the femur to the tibia. The ACL provides stability as you specifically rotate your knee. A torn ACL may occur if your knee joint over-rotates or if you receive a direct hit to the front of your knee. If your ACL tears completely and you have symptoms of instability that do not improve with physical therapy, we often recommend surgery to reconstruct the ligament. For the procedure, oftentimes you'll receive both a combination of regional anesthesia or a nerve block, but also general anesthesia, which allows you to sleep for the entire procedure. During the arthroscopic procedure, I'll make a few small incisions around your knee, at which point I'll insert some surgical instruments, including a camera and other small instruments, to transmit the images to a TV monitor, and the entire surgery is done while watching on this TV monitor. First, we'll do a diagnostic arthroscopy of your knee to look in all the compartments. We'll address any cartilage or meniscus injuries that may or may not have been seen on the preoperative MRI. Then we'll remove the remaining portion of the torn ACL from your knee. Next, we'll prepare your new ACL graft on the back table. There's multiple options for ACL grafts that may be your own tissue or in some cases donor tissue. Next, we'll create the attachment points for the new graft. This occurs on both the femur and the tibia by drilling small tunnels with the arthroscopic instruments. We'll place one end of the graft into the tibial tunnel and one end of the graft into the femoral tunnel, and there are different ways to secure them, but ultimately they will hold the graft in place until your body grows into your new ligament and turns into your new ACL. Oftentimes we'll use small screws to wedge the grafts in place while they heal, and these screws are made out of a bioabsorbable material that actually turns into bone over time, so there's no fear of having large metal screws in your knee. It takes about 6 to 8 weeks for the graft to heal into the bone enough that you can come out of your knee brace and start beginning more activity. So for the first 6 to 8 weeks, you're protected with crutches and a knee brace.